Our given week was in mid-December, when we came to Prairie Heart Institute at St. John's with our photographers to document the cases of some of the multitude of patients who choose this large heart center for their treatment. Richard Neal of Bethany would find himself in the operating room of Dr. William Stevens one day and in the cath lab of Dr. Gregory Mishkol the next. Quite a schedule for a 78-year-old. He wants to get this aortic aneurysm repair behind him so he can get back to work.
I do ceramic tile work, and I'm down on my knees all the time.
Is that right?
Oh, yeah. I just worked 6 days last week.
Ask him how many joints he's had replaced.
Wow.
I've got 2 new knees, I got a right shoulder.
Bionic man, huh?
They,
But you've had your both knees replaced, and you can get down on them and do that
Oh,
work,
yeah.
huh? I'll be darned.
Back in 1907, it was in 07 I got my
2007.
first knee. And the nurse told me I'd be 6 months before I could get down on it. In 4 weeks I was on the job, showing what I wanted done, and I'd get disgusted and
Do it
put my
yourself,
knee pads
huh?
on and get down. You know. So on my 6-week checkup, I said to the doctor, I says, when can I go back to work? He looked at me, he said, you're the guy that did my ceramic work, aren't you? And I said, yeah. He said, if you got guts enough to kneel on it, he says, go, because he said, that knee's stronger than your real knee is now. And I knelt down on the floor in front of him and the nurse and got back up, and the nurse said, oh, we need him out in the waiting room.
Okay.
But before Richard could get back to work, even before he could get his aneurysm treated, he would be getting a bypass graft, as explained by Dr. Mishkol.
So when you met with Dr. Stevens yesterday, he kind of went through things with you, and he was the one who initially referred you to me. Is that correct?
That's correct.
Right. And you've had a repair of this before.
Back in 88.
Right.
Been a long time.
Yeah, right. And then I think you indicated to me you're not eager to have that kind of operation again.
No,
Right.
I don't want to go through that again.
Right. So the problem that we talked about here is that you have this aneurysm here, probably at the ends of one of the repair sites. And it's actually a little closer to the top here than it is to the bottom. So the problem that we face is we want to put this stent in to cover the aneurysm, but we want to make sure we have enough zone to make sure that the stent stays fixed in the right location. And so to get enough purchase, we're going to end up covering this artery here, which goes to the hind part of the brain as well as to your left arm. So our plan is to preserve blood flow to the left side of your arm and your brain. We're going to do a bypass from the left side of your neck to the left arm here. That will preserve blood flow to your left arm and to the back part of your brain. And then that's going to happen tomorrow with Dr. Stevens. And then the day after, assuming everything is good, and we hope it is, we're going to go back in and we're going to put this stent, looks a lot like this, right up to this point here to seal the aneurysm which is coming off here. Now, even when we do this, and we're doing all of this to help prevent the risk of stroke associated with this procedure, there's still a small risk of stroke. And then the other thing is that depending on the curvature of the aorta, you can imagine that if you get this in and it's a very, very acute curvature, you may not be able to get the graft to totally take the curve. And you can still get blood leaking from behind.
I see.
So when I looked at your films, I don't think the curvature issue is going to be an issue, but it can be, where you can have blood coming out of the heart and then leaking behind, depending on how this ends up lying in the aorta. You can never predict how it's going to end up lying in the aorta, but I think all things considered, yours is going to be pretty straightforward. So, it's going to be kind of a rough week, but 2015 will be better.
If you weren't having this other procedure, you'd go home the next day, but we'll just watch you overnight and then do the other procedure first thing Wednesday morning.
Okay. Do you have a time schedule for mine?
For tomorrow?
To be over here.
Mary will, my nurse,
Okay.
because she's the boss and she knows.
All right.
She knows my schedule better than me. I just want to take a listen here, okay? Let's get back here. Make sure I feel the pulse here in your arm. Good. Okay. So it'll just be a little cut just above your collarbone here, about this long.
Okay.
And then hopefully everything will go great Wednesday when we get
It
you
won't,
home.
it won't interfere with your beauty.
No. So, all right, so they're gonna get some blood tests, get everything ready for tomorrow, and then we'll go from there.
All right.
In our patient's particular case, many years ago, he had an aneurysm that had been fixed surgically in the ascending thoracic aorta. He had a surgical repair of that. And then over time, the same disease process that led him to have the thoracic ascending aortic aneurysm affected the descending thoracic aorta. And Dr. Stevens, in fact, had been following this patient over the years and noted that there had been progressive enlargement of his descending thoracic aorta. And we follow those patients until they get to such a size that the risk of rupture exceeds the risk of fixing them. Obviously, if the risk of rupture is less than the risk of fixing, you continue to follow them. But once, and we know what these size criteria are, but once the risk of rupture is greater than the risk of fixing, we decide to fix them, and that's what we did in this gentleman's case.
And the aorta is particularly troubling because it carries so much blood.
Well, it carries your entire blood circulation and then distributes it to the various organs of your body. So when it ruptures or tears, typically that's a catastrophic event. Depending on the location, you could potentially immediately sanguinate, bleed to death very quickly, or you might have some time to present to the hospital. But what it does mean is that if you do get to the hospital and it's burst, you're going to have to do something very quickly. So prevention, an ounce of prevention is always worth a pound of cure. We want to fix these before they rupture.
And in Mr. Neal's case, it's further complicated by the fact that the location of his aneurysm meant that he was going to have a bypass before that could be achieved.
Right. Fixing thoracic aneurysms, particularly the descending thoracic aorta, carries with it a pretty significant surgical risk. So we really try in those particular cases to fix them non-surgically. But as you point out, depending on where they are, you may have to do other associated hybrid surgical procedures to allow you to put that stent graft in.
While Richard rests up to prepare for the next 2 days, 74-year-old Charles Camfield of Mattoon has arrived. He recently suffered a mild heart attack, and subsequent tests showed major blockages and the need for coronary artery bypass surgery. How did you first become aware of your symptoms?
Okay. The first heart attack I had was 82, and that's March of 82. Okay, so I had a little experience when this one come on. I kind of had an understanding of what was going to happen. When I got up, I thought it was my diabetes had started acting up because I was actually sweating, and I thought, well, maybe the blood sugar went down. So I went and tested. It was good, 119, but still I went ahead and did what you do, drank the grape juice, peanut butter sandwich, those kinds of things. It didn't go away, so I knew we needed to go out. So she got up and we went out to Sarah Bush, and they took care of it. It was a fibrillation that it got out of sync, the heart did and everything, and so from then the catheterization, and here I am.
Had you had a heart attack?
A slight one.
A slight one.
Yeah. So
and you had the AFib, or you had the arrhythmia going on
exactly,
as well, huh? Okay.
Exactly. Yeah.
So you knew you needed testing, and then when you got the testing, then it became very clear that you needed bypass surgery.
Correct.
Have you ever had bypass surgery before?
No, this is the first time. Sure.
Yeah. His surgeon will be Dr. Raj Gopaldas. Prior to the operation, we get a rare glimpse of a surgical suite just before open heart surgery.
So this is our open heart OR crew. They're a great team. They are a well-oiled machine. And so we're getting ready to do a quadruple bypass on this gentleman. We're also going to do a procedure for atrial fibrillation. So as you know, there's a lot of equipment. We're heavily technology dependent these days, especially through an open heart surgery. The key for us to be able to get this done is anesthesia or instruments and equipment and the heart-lung machine. So every part of the room actually is vital. We have all our supplies here. Linda is getting organized with all the instruments. We have a little ice machine here, which makes ice actually quite rapidly, because we do need ice to cool and stop the heart and protect it.
You actually put ice on the heart during the procedure?
Yes, we do put ice on the heart. It's a slush. It's a mix of basically water, just like the slush you get, it's smoothie slush, very similar to that, but there's no flavor in it. It's just ice. And we have all the patients obviously on the table. Our anesthesia team. Once in a while, if we're doing valve surgeries or something complex like that, we will have an echo machine here, which is a transesophageal echo, and the probe goes down the patient's throat, and you can actually scan the heart. The heart-lung machine is over there. It's a very important piece of equipment. Can we walk through it? Absolutely. So we have to be careful to make sure we maintain sterility.
Right, we don't
Pretty
touch a
much
thing.
Anything that's blue, you don't want to touch,
Or green.
or green, for that matter. And we have Nadia here, who's one of our perfusionists. She runs the heart-lung machine, and the machine has several pumps to it. Nadia, do you want to tell us a little bit about it?
Oh, sure. So we have a couple of circuits here. We have a main circuit to support the heart and the lungs. When we're bypassing the heart and the lungs, the main cardiotomy, acts like a heart, pumping the flow into the patient, going through the filter and to the patient. Now we have an oxygenator here, which acts as the lungs. It has a supply blend of medical air and oxygen. And we have another circuit here, myocardial protection. When we arrest the heart, we support the heart oxygenated and arrested the whole time to keep it quiet for Dr. Kapaldas. And we have a couple of vents to keep the field bloodless and return all the blood into the main circuit.
Doctor, how long will the patient be dependent on this machine?
Well, the patient, on average, for a quadruple bypass at a maze, you're looking at about average an hour and a half. The heart's probably going to be stopped for about an hour for this procedure. The technology has advanced a lot. When John Gibbon invented the heart-lung machine 60 years ago, technology has tremendously advanced. The big thing here is how we protect the heart when it's stopped, and that's what we have this special solution called cardioplegia. It's a mixture of blood and a high potassium concentration in it. And as soon as you put that into the heart stops. And a heart that is stopped and relaxed is a well-rested heart. That kind of heart is very likely to recover when you try to start it. A lot of patients ask how you actually start the heart, and usually it's pretty interesting. We don't do anything magical to it. All we do is we start infusing normal temperature blood into the heart without any potassium. The minute you start washing all the potassium out of the blood vessels in the heart will automatically start to beat. Once in a while, it does a funny rhythm called fibrillation. You have to give it a tiny electrical shock to get it back. But most times, the heart will actually start on its own.
After a night of rest, Richard Neal is on the table in Dr. William Stevens' OR. The bypass would be successful, setting him up for his stent procedure tomorrow. As they prepare the cath lab for Richard's procedure, Dr. Mischkel is familiarizing himself with the stent and the equipment he will use to deploy the stent. With the help of the company rep, they practice repeatedly until they are certain of success.
Exactly.
Okay.
So go to the black control knob and go to
Right.
position 2 now.
Okay.
And now holding the black, retract the gray. And we want to just flower open the first step. So I'd say keep going, Dr. Mischkel, keep going, so stop.
Right.
All right, so right now you don't have any purchase, but because this stent has a lot of radial force and these don't, you've detensioned the system. So now the technique is to go back to position 1 and use the gray handle, and now you can secondarily place it proximal or distal and get it, as much purchase as you want to get of that thoracic arch. And now where you're exactly where you want to be, you go back to number 2. And now in one relatively quick action, hold the black and pull back quickly on the gray. Perfect. And so now you've deployed the device. It's still anchored on the top.
Now, inside the cath lab, Dr. Mischkel and crew have done all the prep work, and it's time to get the stent into position inside Richard's aorta.
So we also want to orient that dorsal flush port to a little bit 45 degrees lateral.
Okay.
You got wire yet?
Wire?
Oh.
Oh, yeah?
Take this off. I got wire. Yep.
Okay, so can we go live so we can see the tip going up?
Laurel? Come on down. Firm on that wire.
I got tension on the wire.
How's that?
Beautiful.
Dr. Mischkel can see on the x-ray screen that the stent is in position. Remember, it was only a short time ago that he was practicing with this device for the first time. Now, it's time to put that practice to the test.
So I'm in position one. Still in one, yeah. Push this forward, correct? Laurel? How's that? Okay.
All right, so now, ready to deploy. We're going to go to number 2. And you want to do this a relatively quick motion. Pin with the black with your left hand and retract fairly quickly with your right. Go. So now you want to come to the back here.
And do we want to take another picture? I think I moved forward a little bit.
You can.
Take a picture. Suspend.
Suspended.
No, I think we're okay.
You're right there.
That is a very nice result. Agreed?
All right, good.
After the procedure, Dr. Mischkel describes in detail just what we were seeing.
So there's the artery that was tied off, and there's the artery to the left neck. Not quite viewed as much, but right there you can see the origin of it. So my goal is what I did actually during the procedures, I put a mark. I took a magic marker and I put a mark right there. So I knew that I can take my device all the way through the aneurysm, all the way to here, and go right to this point here, and not block flow to the left neck. Because,
okay.
and remember we talked about it when we met him the first time, is that we want to have a long enough neck that we seal this aneurysm, right? So if we had, for instance, if we had put the device here, the neck would be short. Each one of these is a centimeter, so we'd only have about 10 or 15 millimeters of healthy tissue to get a seal zone. So by tying off the left subclavian up here, we've allowed the device to be put to here, and then that gives me 1, 2, almost 3 centimeters of neck to seal. And we oversize the device so that no blood can get underneath. And there's the aneurysm, and then we're going to land down here. So that's all the planning that goes in. And here is the device partially deployed. It's only partially, see, it's partially open here.
Yeah.
And we're checking the position of this little marker here. We're checking the position just to make sure that we are not covering flow to the neck. So there's the flow to the left neck, and there's our little device. I think I pushed it forward a little bit. Go to the next shot. And now we have deployed the device. See, it's totally open.
Yeah.
There's the artery to the left neck. Coming up here, there's the bypass that Dr. Stevens constructed to the left arm. There's the marker device, and I'm right at the origin.
You are.
Yes.
You are all the way up to that new.
Yes. Right. And we'll play it back and forth. So I am very happy with that. As you can see, he's already, the tubes are out. He's off the table.
Yep.
He's going down to the recovery unit to meet his family. And we're ready for the next patient in
I'll
here.
tell you what, he's had a rough couple of days, but he came through it pretty good, didn't he?
He is a tough guy. I think you heard him. He wants to go back to tiling floor at age 78. But isn't that amazing? Who would have thought that somebody had such a large amount of cardiovascular disease would at age 78 be tiling floors? And I think we see this time and time again, whereas in the past people felt like they became cardiac cripples, we're in the business of creating cardiac athletes.
There you go. There you go. And now you'll know who to call when you need that floor too.
Yes, you're right. Don't think I haven't thought about that. Hi guys. I know you're nervous. Dr. Mischkel, how are you?
Hi.
Good to see you again.
Yeah.
It went fantastic. No problems. He is a tough character. You know, yes, he had an operation on his neck, and then today he has this, but he's actually, I think they've extubated him and he's waking up. So we got a very, very good result. I think as good as you can possibly get using this technology short of operating on the patient.
Still better than breaking their chest open.
Well, it's a big operation, especially when you're talking about a redo.
Mm-hmm.
I mean, he's already had one aneurysm repaired and then developed new. Now his whole aorta is got issues in terms of being diffusely diseased, and it certainly is possible that he could develop over time areas of new aneurysm or
Mm-hmm.
even leakage around this graft.
Yeah, you said something about
that is possible. There are some advantages in particular to this specific graft that I think would reduce the chances of leakages, but we can't prevent Mother Nature and further wear and tear on the rest of the aorta. So, assuming everything stays well, we could probably let him go home tomorrow afternoon if everything stays good. And we did this without the need for any surgery, just with a needle stick, and that repair looks good. And so he'll just be left with 2 little holes in the groin.
And a lot of bruises.
Yeah, he will be bruised. He will be bruised. But all things considered, not a bad Christmas gift.
No, he wasn't done close to Christmas because he's not as busy usually then.
What kind of work does he do?
He puts ceramic tile down.
Oh my gosh.
Yes. He'll be wanting to go back to work Monday.
How old is he?
78. He'll be
78.
79 in June.
Shouldn't he be relaxing?
Should be out fishing somewhere, but he would like to do that, but he's got to work. He just has to work.
Well, thank goodness there are still people like that around, huh?
He must work till he's 85.
Good for him. Well, my job is to make sure he gets there, okay?
Yeah.
Okay, guys, have a seat outside. We'll let you know when you can visit with him, and he'll be going back downstairs to the cardiac recovery unit, okay?
All right,
Okay.
All right.
Good to see you guys.
All right.
See you later.
Thank you.
The news was good for Charles Camfield, too, after Dr. Capaldi's performed the triple bypass.
Mr. Camfield ended up getting a triple bypass.
A triple?
Triple bypass. One of his arteries was too small and too calcified because of atherosclerosis, and I didn't think that could be bypassed, but he got a triple bypass. I did the ablation for the atrial fibrillation. Everything went very well. His heart came off the heart-lung machine without any problems.
Is that the time during the CABG that your most worry is bringing the patient off the heart?
Correct.
machine?
That's usually the critical time because 2 things are happening there. One, the heart is trying to recover its power, its energy. At the same time, you're also turning the heart-lung machine down. So it's a critical time, and if the heart struggles and is not able to hold on its own, then you end up having to restart the heart-lung machine and try a few additional tricks to get the heart, or rather coax the heart to get back on its own.
Yeah. What would be, in Mr. Camfield's case, what would be the prognosis for him in the next few days and even the next few years?
I think in the next few days he's going to do fairly well. There were no technical issues or challenges during the surgery, so typically when you don't have any of that and their heart function, or we call that the ejection fraction, and the heart power is good and the heart function is good, they usually go through a fairly smooth sailing course. He would probably stay in the hospital on average about 4 to 5 days. Their recovery is a little longer though. For a month they're going to be tired, they're going to be sore. It takes about 4 weeks before they can start doing more and more activities, but we encourage our patients to stay as active as possible, but anything short of lifting heavier things. You do want to let the breastbone heal. And it's like a fracture. It takes 4 to 6 weeks to heal.
Yeah.
It's a surgically created fracture, and we put steel wires around that. So as long as you let that heal, in 4 to 6 weeks they can start getting into a rehab program where they build their strength and activity and whatnot.
He's not a young man, so
No.
what does it look like for him in the long term?
Well, in long term, one of the things with atherosclerosis that causes coronary blockages is the disease process continues to progress. So any patient who's had a coronary bypass has the understanding that a bypass surgery is not a cure. Bypass surgery is kind of a temporary solution to redirect blood into the heart more effectively so that the heart can continue to recover. But what's going to prevent new blockages from forming is actually your diet, your exercise, lifestyle, awareness of your surroundings. And the last thing, which you really cannot do much about, is your genes. That's something you're born with. And there's clearly a genetic predisposition for some people to develop coronary artery disease and blockage. So you can't do anything about that. But when you realize there's a strong family history of coronary disease, it becomes all the more important that you have to be very careful with your diet, lifestyle, not smoke, and regular exercise, cardio, stay active, and things like that.
Mr. Camfield was groggy and hurting, but he kept a stiff upper lip, and he kept his promise to talk with us after the surgery.
Doctor says you're doing well. How do you feel about it?
Well, very well myself. Yeah, a little groggy right now, but then that's what it's all about.
Yeah. He says a couple, 3 days,
Yeah.
you can go home.
Yeah, that sounds good, doesn't it?
It sure does. It sure does.
And Richard Neal can get back to his flooring work soon.
Congratulations.
Oh, I tell you what, I feel like $1 million.
I understand you're going home.
Yep.
It's pretty amazing,
That's
isn't it?
what, 2 days?
Two days, and you had a lot done.
Yeah.
Yeah, you had this bypass put in here,
Uh-huh.
and then you had your stent, right?
Yes.
Put in your aorta. Yeah.
I can't believe this. I haven't even got to see it yet.
Is it sore at all?
No.
It's not sore. You don't hurt anywhere?
I was telling Mary a while ago, I've only had 2 pain pills, 2 Tylenol with a
Is that
little
right?
bit of codeine in it.
Yeah.
That's been it.
Yeah. And you, I mean, you're ready. You're ready to go home and start living again, huh?
She told me I could go back to work Monday.
And that means laying those tile floors again.
Light duty. She said no heavy lifting.
Yeah, but you can get on the floor if you want to and lay that tile.
Yep.
That's incredible. That is incredible.
I'm going to go till I'm 85.
Yes, you are. Well, at least.
Richard will be going home soon, but the journey is just beginning for many others, as we will see on the next edition of Cardia in Any Given Week.
For a DVD copy of the program you've just seen, send $19.95 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.